And let's just do a walkthrough of how we would look at the factors, how we would possibly put this case together. So let me go ahead and pull that up here, Tom. I'm going to put this on full screen, share my desktop, and I'm going to put in what you sent me here. This is what you sent me. So go ahead and give me, let me give you a quick brief review real quick. And remember, there's 4 things that we're trying to do here with our case. We're trying to, number one, remember the 4 pillars of personal injury marketing is, number one is we have to establish cause and effect. And that has to do with a detailed history of the mechanism of injury. So we want to show that the mechanism of injury caused this damage, and that does, and there's some specific things we want to look at in our investigation that are going to influence that. So that's number one, that we want to definitely show that this injury was caused by that accident, number one. Number two, now we want to objectify that injury as best as possible. And obviously there's subjective and objective. We want as much objective evidence as possible, but subjective evidence in addition to objective evidence is very beneficial because it helps tie everything together. You certainly do not just want subjective evidence. And when we use the objective evidence, we want to use third-party trusted sources that's well known, that essentially can't be disputed. And so that's the second pillar, is the objectification. And of course, it's nice if we could measure it, the quantification, if we can measure it. So we need to objectify and measure these particular injuries. So that's the second pillar. And of course, the third pillar is the therapeutic protocol. And really that involves 2 things, is what treatments did you do? And of course, the therapeutic protocol should totally based on the physiological effects of the 3 phases of healing. And because it's also third-party trust. So that cannot be challenged. Those are physiological facts. So that's why we use those also. So the therapeutic protocol is, why did you do what you did relative to the 3 phases of healing? And then benchmarking. What was the progression of the patient, and with re-exams and functional capacity tests? So that's the third pillar. And then the last pillar is the prognosis and statement of permanency. So when we connect all the 3 previous pillars to support and document the case. So that's the 4 pillars of personal injury. So let's go ahead and walk through this particular patient with how we'd set that up. So we've got the patient, and we're dealing with a particular client here. And without me reading specifically the quick history of this, Dr. Tom, is what?
Well, he was basically in a big work van, stopped really fast in traffic, got hit 2 cars behind him. A car hit a car, then pushed another car into him. And he said his car lurched forward about 5 feet, didn't see him coming, head went back into the headrest, and had some low back pain, neck pain. He still was able to go to work, but didn't do anything. This guy is a 6'4", very in shape, very hard worker, prides himself on that. Fell off a roof about 7-8 years ago and messed himself up pretty good, but it was pretty much, he used to come see me once every week or 2, just for a little tune up, felt pretty good most of the time. But this car accident really, he hasn't been able to work at full speed ever since, and it's been about 3-4 months. And he did this back in early January.
Okay, so let's go ahead and use this case and just kind of walk through some of the basic factors here. So remember, when we're looking at the mechanism of injury, I always talk about start from the positioning from internal to external. And so where was the person in the particular vehicle? Where were they at position-wise? So we're going to look at that. Then remember, the major factors we're going to look at are not just the forces, but also the joints, were the joints locked out or not? Because remember, there's also what's called active, passive, and joint motion. And remember, after joint motion comes anatomical failure. So it's active range of motion, passive range of motion, joint motion, anatomical failure. So if the person was already locked out in passive range of motion, in other words, the joints were already locked out, that means there's that much more force going into the anatomical damage as opposed to going through more of the motion sequence taking up the energy. So we're going to pay attention to where the joints locked out. So what does that mean? The positioning of the patient. How were they turned? How was their body turned? Their head, up, down, left, right. And so I'm paying attention to where the joints locked out or when the injury occurred and how the forces occurred with those particular joints because some joints move in different directions. So what if there was forces in a joint that doesn't move, like let's say a flexion extension joint, and the forces were lateral? Well, that's way more important, more of an impact injury than if it was a flexion extension impact where there's natural motion flexion extension. And if the joint was locked out, so there's no more motion. So you can see I can have a much more greater impact with the exact same injury if the impact was going counter to the normal motion of a joint and the joint was locked out. I'm going to have much more higher probability and likelihood of anatomical failure and injury. So that's what I'm paying attention to and why relative to the positioning of the body. Now, also remember the defenses. Were they defensive? Did they see it coming? Because if they were tense and saw it coming, that'll absorb some of the shock, as opposed to if they didn't, then all that energy is just transmitted right into their joint, spine, and tissue. That's an important factor as I put this case together. And of course, all these things are going to be very relevant in my narrative and reports, in my final report. So were they defensive? And then obviously the impact, what was the first, second, and third impact? How many times did they hit something in the car, front, back, left, or right? What anatomy impacted it? I'm going to be paying attention to that in my course. And then the material, what did they impact? Well, a steering wheel is much harder than a soft cushion of a seat. So I'm going to pay attention to the material that they impacted. The seat belt. The seat belt really, is really, it kind of helps. What happens with seat belts is the number of injuries, the number of deaths definitely decreased, but the number of injuries significantly increased, especially how they were wearing the seat belt. Some people wear a normal seat belt, whether it's a triangular seat belt, and I don't wear a seat belt like that. I put the seat belt under my arm. Well, that's going to have different ramifications with injuries to my ribs, etc., in an impact. So I want to know just not only if they were wearing a seat belt, but also, and a lot of the seatbelt has to do with liability because they become more liable if they're not wearing a seatbelt as opposed to also on medication and alcohol and things of that nature. And the other reason that you want to do this is, and this is a very common issue, is you want to discover things that may hurt your case, like if there was alcohol or drugs or diabetic. In other words, there was some liability on the actual victim's part. You definitely want to know that and not ignore it. And that's what happens, I say a lot of times, is people try to suppress it and ignore it. I'm like, no. Same with the pre-existing. You want to know if they had these problems before because I can position myself in the narratives and reports and testimony and depositions to minimize the impact of that. The worst thing that you could do is not record that information, make all your assessments, make all your judgments, and then they find out they wasn't wearing a seatbelt and they were on alcohol and they had pre-existing and you didn't document any of that. Well, number one, you're going to lose a tremendous amount of credibility, and that will snowball effect on you. So everything negative about the case to the victim, you want to find out. You don't want to hide it. And so you want to document it, and then you can put it in its perspective. And we'll kind of talk about that, especially with this case, because this could easily, right now, remember, if I'm an attorney, there's 4 ways I'm coming after this case to not get my insurance company to pay. I'm going to attack you personally. I'm going to attack chiropractic. I'm going to attack the objectivity of what you did find. And then I'm going to minimize the cause and effect relationship and say this was pre-existing. So I'm paying attention to that as I'm accumulating my data to get ready for what's coming down the road. I don't want to wait till that happens and I didn't take this information. So in this case, like he was a previous patient. Well, we're going to want to say some things very specifically relative to that right now when we take this history to help differentiate the injuries or pain syndromes before versus now, to help deflect and minimize them coming in and saying, well, no, they had this before and you treated them before. So those are factors of consideration. And I talked about intoxication, and that also is not just alcohol, but also drugs or diabetics. In other words, any mind-altering state. And again, you want to know these things so you help minimize them, because if you don't, they will come back and really hurt your case. And then the obvious things is the weight of the vehicle. What was the mass of the vehicle? Because force is mass times acceleration. So we're going to want to know, what kind of car they were in. We're going to want to know what kind of car they were hit. Those are obvious things. And again, we talked about the positioning of being hit. The vehicle hit. Let's see, what do we got here? The number of times maybe the vehicle was hit. The weight of the vehicle that hit them, obviously that's going to be relevant. All these things can add up where I can take a case that doesn't look like a whole lot, and once I put some of these things together, it becomes pretty obvious that all these factors helped create this problem. Conditions of the road, was it wet or dry? We talked about some of those things. The amount of damage to the vehicle. Was the person hospitalized? Did they go by ambulance? Did they drive there themselves? Did they go the next day, a few days later? Did they see any doctors, any treatments, medication, limitations, restrictions, hospitalization? So these are some of the major factors we're going to look at when we're digging in the history. So having said that with this case, let's go into this a little bit. Okay, Tom?
Okay.
And from best of your knowledge, let's just go. He was the only person in the car?
Yes.
Okay. And he was the driver?
Yes.
And what kind of car was it that he was in?
One-ton Chevy van.
Okay, so a big car, and so the road conditions were probably good, not wet, right?
I don't remember.
Okay, so we'd have to get that. So the car that hit him was what?
I don't know.
Okay, you need to know.
I think it was like a BMW, like a sedan.
Okay, see, those aren't as. But remember, it's always better to have the information and relate it than be caught off guard, because your credibility will suffer greatly when you say, like you said, I don't know. I mean, that's not a good thing to say when you're in a deposition or in court. And you made statements of permanency. So, so he's in a bigger vehicle hit by a smaller vehicle. Let's say there was okay road conditions, but you said he skidded, or what happened? He moved the vehicle 5 feet or something?
Yeah, he got hit hard enough in his van. He said it must have jumped forward about 5 feet from the impact. Okay, and you need the police report to verify this information, such as what you just said, because that's a major factor. If this vehicle, this huge vehicle, actually moved, this multi-ton vehicle moved 5 to 10 feet after the impact, that kind of gives you an idea. Well, a smaller vehicle moving a large vehicle 10 feet, that's a major impact. And also in the police report, they'll talk about, the speeds, get relevancy of speeds. Nothing's really definitive this or that, but all these things add up the more of the pieces of the pie you put together. So what was the speed of the vehicle on impact, No, we don't know. A car hit another car that pushed the BMW into him.
Wow.
Yeah.
Okay.
Yeah.
The bad news about that is it was a secondary collision, which now that car that hit him absorbed some of the force and decreased the amount of impact. But, that's a major, to move a smaller vehicle you see, I got a red flag right there. That's a major. If I got a smaller vehicle to move a larger vehicle like that, 5 to 10 feet, I'm definitely making sure that is well known in my reports and my narratives as far as the amount of force that was delivered for that to occur. That's major. And then let's go to him. How was he impacted? What did he hit?
Well, he just hit backwards into the seat rest. He didn't, he doesn't remember going forward and rebounding into the steering wheel or anything like that. He said, I just got snapped backwards into my seat.
Did he know he was going to get hit?
No.
Okay, so that's important, right? So now he's defenseless when this force comes, which means there's that much force, more force going past active, passive, and joint motion into anatomical damage. I'm going to be saying words like this in my reports and narratives. I'm going to be talking like this. Everything is based on the 3 phases of healing and 3 ranges of motion, inflammation, repair, and remodel. So I'm totally substantiating this. So he gets hit from behind. He hits the back seat rest. Did he have it up? Do you know?
He's really tall. Even if he had it up, it's not going to be all the way positioned properly.
Okay.
He's 6'4".
Okay, so we don't know. You can't make a statement you don't know, right? But
no.
If it wasn't up, that would even be that much more force with the tendons and ligaments and overpressure and anatomical failure and all that. If it was up, then there's more possibility of damage, of neurological damage because of the the brain collide, the skull stopping and the brain keep going. So you see how I'm always looking at these from a perspective to help support this injury and this damage. Okay, so as far as you know, he just kind of hit back. Do you know if he had any of his joints locked out? Was his head turned or looking in the rearview mirror or anything?
No, none of his joints were locked out.
Okay.
That I know of. He was just looking straight ahead. Maybe turned his head slightly, but no, he was just looking straight ahead.
Okay. All right. All right. So we got those factors in. Seat belt. Was he wearing a seat belt?
Yeah.
Okay. So you got a lot of stuff. You got a lot of information right there relative to the mechanism of injury. Some key points I'm paying attention to. The biggest key point that I'm hearing right now is that car moved. That is a major, major issue to get a smaller vehicle to move a larger vehicle. And not just a smaller vehicle to move a larger one, but on a secondary impact. That takes tremendous force on a secondary impact to move a smaller vehicle. I'm making a significant statement in regards to that. And I will also place emphasis on he wasn't protecting himself. So that means all that force was delivered unguarded and went all into the tissue and damage, going past the ranges of motion into anatomical damage. Those are some of the key things I'm just seeing right away. That's some major stuff right there. And chances are you won't see much damage to a large vehicle from a small vehicle. Chances are you won't. But I'm going to make sure in that police report, I need third party. I want to have that third party documented. I'm going to make sure I get that police report. And I want to make sure somewhere it's documented in there, the skid marks or how far that car was moved, because that is a major force factor. Okay. Anything else relative to that? So we talked about the positioning of the person, the joints locking out, what they hit, the possible damage with whether it's neurological or a musculoskeletal or a combination thereof. Did they black out at all, or do you know?
No.
Okay.
Didn't black out at all.
Yeah, you always want to ask if they blocked this. If somebody blacks out, that's an automatic 6% impairment rating right there from a mild concussion. Just from blacking out, just even for a second, just blacking out. That's a brain bruise. To black out, your brain has to be concussed. So, okay, so we got those factors. We got the weight. So we kind of have a pretty good idea of the injury here, don't we? It's a pretty a big impact, a big guy. A lot of force to get it to move that way. It was very directional, no protection. So here we go, right?
Right.
Okay. So I'm going to be putting all of those dots together in my summary of the prognosis, establishing cause and effect. So that's that much more information that I'm going to be able to say to totally give more credibility to cause and effect of the injury. Now, I am going to want to minimize some of the negative effects. Let's see, he was wearing a seat belt, so that's good. Let's see, the pre-existing. Let's talk about that. Anytime you have the patient, you're doing the history. Remember, I'm always going to get attacked for pre-existing. So I always want to identify the symptoms, restrictions, or limitations of ADLs or work with that person specifically prior to the injury. Let me say that again. I always want to find out. In other words, let me simplify it. If the person said, I got neck pain. Okay, let's say that you find out they have neck pain every day now. I want to know, prior to that accident, did they ever have neck pain in their life? And this is where a lot of doctors make mistakes. They don't go for, because they're afraid it's going to hurt the case. Well, it hurts the case when it comes out in a court or trial or deposition. That's when it really hurts the case. So you do want to find out if they had that problem before, prior to this injury at all. And you want absolutes, yes or no, yes or no. Now, if they did, the main factors you want to consider and document are what was the frequency of the neck pain if they had it before? What was the frequency or intensity of the neck pain if they had it before? Because I'm going to do a parallel in my report. I'm going to note that. Well, now they have neck pain daily. Before they had neck pain on a scale, and I'm going to quantify it too. So now they have neck pain daily on a scale of 1 to 10. It's a 7 after the accident. And prior to the accident, they had neck pain once or twice a month, and it was only a 3. See, now I have credibility. I've quantified the pre-existing, and it helps minimize the attorney from saying, oh, this previous stuff was way more attributable than what is going on now. In other words, I put it in its perspective and it gained credibility. So the factors I want to look at is whatever symptoms, restrictions, or limitations they have now. You want to go prior to that accident. Did you have these at all, yes or no? If you did, how often did you have it? Frequency. And what was the severity? Scale 1, preferably try to quantify it, scale 1 to 10. And what did it restrict, limit, or inhibit prior to the injury? Well, what if there was no restrictions with work, with the neck pain prior to the injury? And now they have trouble or they can't work, or they had to take time off from work. See, I put it in its perspective, and I help minimize the attack of saying pre-existing. So frequency, intensity, and restrictions or limitations. Specifically, what you're looking for is ADLs. It's essentially the enjoyment of lifetime activities, duties under duress, but essentially you start with the ADLs. And then if they did, what did they have any restrictions or limitations in? And quantify it. What was the frequency or the amount of restriction? Now I got it in total perspective. Let's say prior to the accident, they had a neck pain maybe twice a month, scale 1 to 10, 3. Now it's daily and it's a 7. And they could only, let's say before, maybe they noticed, maybe once a month they had a little trouble sleeping with the neck pain, and they come in and they got care, okay? But now they have pain and discomfort every day sleeping with their neck pain. See, I have, number one, I got credibility, and I stopped myself from getting whacked and losing a tremendous amount of credibility in a deposition or in court. And I put it in its relative perspective. So it really helps minimize the attack of the defense trying to put more emphasis on that. So those are the factors I'm going to really pay attention to with pre-existing. So right up front, I'm already defending this case. I'm not only supporting it, but I'm going into documentation to defend it when this comes to a deposition down the road. Any questions about that?
No.
So By the way, your previous records are going to get pulled on this patient. You know that, right?
Yeah.
Okay. Now that's good and bad. The good news is if you did your work right and you did periodic re-exams, you're going to have a baseline. And this actually happened in one of my cases. The patient was a previous patient. So you should have a baseline of a pre-existing re-exam with certain tests versus your new re-exam after the injury. And you'll see a difference. And the example that I give is in the deposition I was in. I remember this distinctly, that the attorney said, well, this neck pain has been going on for the injury and to any degree. In other words, they knew they were trying to pay, but they were trying to minimize how much they were trying to pay in the case. And these are things they do. So he goes, well, he already had neck pain. He had this problem before this. He was a patient of yours, wasn't he, Dr. Holler? And he had neck pain, and you treated him for neck pain. Yes, 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 yes. Doesn't look good right now. Until I pulled his record, and I looked specifically, I did a quantitative, qualitative analysis, test by test. And it just so happens, the last re-exam that I did with him, the foraminal compression test was totally normal bilateral. On the re-exam findings, or excuse me, on the initial findings of the new injury, they were positive. So I could say with total affirmation that his symptoms had nothing to do with his previous injury. And how can I say that? Because when we examined him, he had no positive foraminal compression test. It was totally normal, which says there was no problems or lesions there. And when I do it now, they are, which says, yeah, he definitely has a lesion. And that was a huge, that one test, a foraminal compression test, helped position the whole case. Okay, any questions about that?
No.
So you're going to want to make statements to that fact. You're not going to want to hide that he wasn't. You're going to want to say he was a patient, say what his frequency, go to his last re-exam, go to his symptoms, go to the frequency, go to the quantification of it, go to any limitations or restrictions he had, and specifically identify the tests that were not positive. In other words, I'm going to highlight this in my report to show greater emphasis that this caused that. I will say these tests were normal, and after the re-exam, it was positive. And not only was it positive, remember, it's quantity and quality. Quantity and quality. So I'll not only go to positive, but how can I measure it? How can I quantify it? So I want to make sure I make those statements in my reports and narratives and not hide from them. Put them in their relative perspective. Okay, any questions about that?
No.
Okay, so we're kind of done with the first pillar, right? First pillar is establishing cause and effect, right?
Yeah.
Okay, now let's go to the next pillar. Next pillar is the objectification of the injury. So he's got neck pain. What was his other symptoms?
And back pain and headaches.
Looks like he has thoracic and back pain, neck pain, and low back pain. Mid back and low back.
Yeah.
Okay. Good. And you did your studies here to quantify it.
Yeah.
Okay, good. And you can see how that's very helpful if you've done these studies in the past prior to his accident, right?
Right.
With a comparative analysis. So that's real good. So what would we typically do with this case? Well, we have his symptoms, right? We got frequency, duration. We've got the quantification, scale 1 to 10, those basic things. We've got, let's see, we've got his orthopedic neurological range of motion testing, right?
Right.
So we would do the basic, ranges of motion. And remember, I talked about the emphasis of ranges of motion, that chiropractors generally don't deal with active range of motion dysfunction. Initially they do, but it's not typically a neurological or joint issue that restricts active range of motion with the typical chiropractic patient. It's pain. Pain is typically what does. It's not a muscular lesion per se. So I'm paying a lot of attention to the let's see, the you got his subjective all his subjective findings. You've measured that. Then you did his orthopedic neurological exam. In the orthopedic exam, I told you we're paying a lot of attention to range of motion with overactive and overpressure, with an emphasis on extension, range of motion. Those are joint specific tests. Those are very specific for going into joint lesions past active range of motion. The other tests that are real common are the compression tests with joint lesions, right? Femoral compression, lumbar compression, right? And palpation. Even though palpation is a subjective, somewhat, more subjective, but you can identify muscle tone, tension, restriction, heat or cold, you can identify those, but it's certainly what we would call a little more subjective. But it's a combination of the subjective, the halfway findings that are kind of subjective, quasi-objective, and then the definitely objective test. You see, it's the combination of all those things of putting them together that takes this case to a whole nother level. It's usually not one thing in particular. So those are the common findings. So what else did you find here? You got your ranges of motion, you got your pain levels. You good? You did your pain levels, and then your neurological testing. Basic neurological testing. You did your strength, sensation, dermatomes, reflexes. Those are rare.
Also not included on this, I do the thermal and surface EMG tests too. I got the subluxation station. I've had it for 8 or 9 years. So I scanned it, but I didn't give you a copy of it. I don't know if you like those or not.
Okay, well, it's not me what I like. What's it based on?
What holds up in court
and what holds up in court? Your opinion, your factors that have already been established and accepted in medicine or not?
Yeah, I don't know. Have they been established and accepted? The people who sell the machines say they have been.
Okay, so you think that the components of a subluxation, because that deals with, there's 3 components of that subluxation station, right? Range of motion?
Yeah.
What's the other 2?
The 3 components?
Yeah.
I don't remember. What is it? Range. What are the other 2?
It measures. Doesn't it do? What did you say you had? I thought you said you had thermographic or something.
Yeah, I have a thermal scanner. Just basically it checks, it compares temperature on
Okay.
the skin on the right and the left.
Okay,
side.
so you have a thermal scanner. Are you talking about like a neurocalometer?
Yeah, exactly.
Okay. Well, how well is the neurocalometer established in medicine?
Medical doctors never use anything like that.
How well is it established as scientific in medicine?
Yeah, probably not at all.
It's not. It hasn't shown to have high user reliability testing. So what did I tell you about third-party objective testing and being very careful what you use and not using this chiropractic stuff? You take in these diagnostic tools that are chiropractic that are not accepted as science in the scientific journals. I'm going to have a field day with you in that stand. If I'm halfway of an attorney, I'm going to go into journal after journal. Where is this in the scientific journals? Okay. Now, I'm not saying it's right or wrong. I'm just saying that's what our culture, the United States culture, is based on. I'm not saying if it's right or wrong. So we have been sold on scientific. What's kind of generally the definition of scientific? Well, if it's been in scientific journals, in other words, what are considered as peer-reviewed journals. Is there statements of? I'm not talking about a chiropractic journal that's not seen as a peer-reviewed journal. Because there's chiropractic journals out there that are not deemed, that don't fit the qualification of, JMPT is kind of a peer-reviewed, medically accepted journal, right?
Right.
Well, there's other journals that aren't, but they're, within the chiropractic field. Well, this isn't a chiropractic thing. This is a healthcare thing. And what do the people, the jurors, remember, everything is based on a jury. That's who's going to be the final sayer in this whole case if it goes there. So everything that I do, I need to make sure, well, what's the jury's perception and credibility of whatever it is I do? That's why I never did anything that was not peer-reviewed, scientific based, and I stayed totally away from this chiropractic stuff. You bring in this chiropractic like a neurocolometer, all that stuff. If you have a decent attorney, he's going to destroy your credibility. It's very easy to destroy your credibility, you bringing in non-scientific stuff. And I'm not talking about chiropractic. I'm talking about medical, because this culture has been sold on medical. Okay? So is that something that I would even bring in? I wouldn't even bring it in. And the reason I wouldn't bring it in is because he has the potential to destroy me on the stand. Because now what's going to happen to me, to my credibility, when I try to say something that is actually credible?
Yeah, you lose it.
You diminish what you are credible at by bringing in stuff that is quasi-credible. And if you're a good attorney, and if I put you on the stand, I'm going to spend 3 to 4 hours talking about peer-reviewed journals and where it's at. And I mean, I'm not even going to be talking about the patient. I'm going to go after your credibility. Okay? So what else did you say you had? Thermographs and what else?
And the other one was the SEMG.
Okay. The surface EMJs aren't seen as credible, are they?
I don't know. I don't think so.
No, they're not. No, they're not. Those are chiropractic stuff too. Do you see surface EMG diagnostic tools in the AMA guides?
No,
no, you don't. No, you don't. You see NCV and EMG's needle, don't you?
Right.
Okay. Those would have been called peer reviewed. Okay. In other words, how much reliability has surface EMG showed amongst diagnostic practitioners? Well, you'll have a difference in test when you're delivering that test in the winter in Minnesota versus the summer in Florida. If the person's doesn't have air conditioning in the room. So I need you to be really aware of paying high attention to these diagnostic protocols that are medically scientific review peer based and not stuff that will easily hurt your credibility. Any decent attorney is really going to have if an attorney hired me to counter you, I'm licking my chops right now with that subluxation station. I'm going to destroy your credibility. Do you understand that?
Yeah, I understand what you're saying.
Okay. And it's not me. It's on the stand and what can be shown to destroy you. It's not my opinion. Okay, so, and by the way, they'll go after everything, even if it's scientific and all that. They'll still go after it. I mean, you got to go after everything for the, not really, but sort of. But you certainly leave yourself way open. That's why I never did any diagnostic tests that were not standard medical at all. And it was all third party. That's why it was all based on the 3 phases of healing. Nothing on chiropractic. That's why all the tests I did were totally 100% accepted, medically accepted, peer-reviewed tests. That's why. I mean, it's going to be much, much harder for that person to even try to come at me. Okay, any other tests you did?
No.
Okay.
Well, I did x-rays and flexion extension a few weeks ago, and he's going in for an MRI in another week or 2.
Okay. And I see, you got your orthopedic test and all that. And they'll even, like a straight leg test or a positive palpation or stuff like that. A good attorney will challenge that in its objectivity, right? I mean, yeah. That's you got to know how to handle that, but that's not a clear total objective test. But when we use that in association with all these other parameters, we start building a watertight case, or a pretty tight case, if not watertight. Okay, so those are your orthopedic tests, etc. So let's pull up your x-rays here and take a look at them. I don't know if this is the guy. This is not the guy, right? unless he's
That's a female.
unless he's wearing bras lately.
I hope it's not the guy.
Yeah. Okay. So is that the guy?
Yeah.
Okay. Now this was left lateral bending, wasn't it?
Yeah.
If I remember, this was not an AP, a neutral AP view. You actually were having him bend to the left.
Yeah, he's going as far as he can. He's in pain right now.
Yeah, and see that's what we talked about before. These are very clinically significant objective findings now. Now this X-ray on its own, without the history and the findings and all that, is irrelevant. But when you put in his history, the trauma, the signs, the symptoms, all the other corollaries, this becomes very important. So now we obviously have significantly altered intersegmental motion. These bones are moving wacky. So this is a good example of altered intersegmental motion. Depending on the case, I might want to do a computerized radiograph mensuration analysis and look for things like AOMSI. But even if he doesn't go into the category of AMSI, I don't have to measure this for me to look at this and go, that's altered spinal mobility. He not only has abnormal coupling from left to right bending, but he has abnormal rotation. And I can pinpoint those areas, right? Just by looking at the spinous process and the rotation and the transverse in the body. So I can already say where there's abnormal rotation and then intersegmental. Obviously right here, there's hyper. I mean, it's even slipping right here. You probably have some ligamentous laxity right here. You probably have AOMSI right here. You see that?
Yeah.
Okay. And so that can be easily measured. And especially when you do, remember, if I'm a juror, let's compare that one and then I show them that one. I didn't even show them normal yet. Because remember, I'm always going to show normal to show a jury abnormal. So here we got right lateral flexion. It's a little more congruent. It's locked up. It's definitely hypomobile segments, but it's the same thing with rotation. We got nothing for rotation in there. So if you look at them one to the next, look at that. You have hyper intersegmental motion, L3 to 4. So, I mean, that's a pathological condition. I guarantee you you got some ligament issues here, compounded, this whole injury. And then altered intersegmental, and then you've got definitely altered intersegmental motion here. Probably doesn't rise to the level of AOMSI, right? If we were actually to do a computerized radiographic mensuration and look at translation, even though it's not a flexion extension view, we're just making some educated, calls off the bat here. Does that make sense?
Yeah.
So I'm going to point all that out. I've got a lot of good stuff to show on the biomechanical motion, on the X-ray findings that totally relate to the injury and relate to the 3 phases of healing and the 3 ranges of motion. It all connects. I've got to connect those dots. Did this person end up having normal lumbar range of motion when you finished with them?
No, they have very restricted range of motion.
Okay. Because sometimes you see that. Sometimes you have normal gross range of motion and you take the X-ray and then you see stuff like this. And you're like, holy smoke. Well, that's way not normal. So that's that other one we looked at. This is the same patient, isn't it?
Yeah, that's extension film.
Okay. So same thing here. We're looking at George's line and any ligamentous laxities. We'd look at any angular deficits. And again, I'd have this one read digitally, right? I mean, this is a pretty significant injury in case. There's a lot going on here. I'm probably looking at having these read, with computerized radiographic mensuration analysis. I'm having this spine measured. I'm going to find some stuff here.
Yeah.
Okay. So you got extension here. We're not seeing anything really. A little bit here. If you look at the posterior, plates right there, a little bit of a stepping off there. But I'm going to get this read. There's just too much going on here. And then there's your lines you drew. There's your flexion. And obviously you can easily see altered interseg motion on flexion. You know, and that's why I say sometimes if you take a piece of paper and you cover up half the spine, it helps accentuate the movement, the intersegmental movement of the 2 or 3 motor units you're looking at, as opposed to looking at them at all. It's harder to see sometimes, but I could easily put a piece of paper right here from here down, and I can easily see decreased mobility, you know, right here, 2, 3, 1, 2, 2, and 3. You have a stepping off effect. Look at that right there. You got the stepping off effect. So you may have some ALMSI right there. So you have hyper mobility right here and hypo right here, right?
Yeah.
Okay. I mean, I don't even have to look at a mensuration report to see that. I can see how one vertebra moves in relationship to the other, especially when I do a comparison of the other vertebra, or if I'm looking at a normal. And that's without even doing a mensuration analysis. So, you know, so look what you got here. You got definitive cause and effect. You got definitive symptoms and signs. You have definitive objective findings that totally correlate to joints and mobility, active, passive, and joint range of motion. You got definitive objective analysis. You see how this case is going?
Mm-hmm.
Now,
yeah.
you think I'm telling the attorney this?
Yeah.
I'm letting him know, get ready, load for bear. Because am I going to be able to take this case and put this together and totally support whatever that attorney wants to do in front of a jury?
Yeah.
Now, if that attorney's not educated, what's he going to do? He's going to want to just process this through because there's not a broken bone in his body, right?
Right.
Did this person, do you know if they had any disc lesions? Did you do an MRI?
No, we're trying to get that. This was he was in a work truck, so it's an L&I case and a PI case. So anyway, we're trying to get the MRI approved through L&I first. And
okay,
so he's scheduled for an MRI in the next 1 to 2 weeks.
Okay, so the answer is no. You don't have an MRI right now. But can you see can you see if you did not, let's say I think he's probably going to show some MRI signs, just with everything I'm seeing. But let's say he doesn't. Can you see how an uneducated attorney is at a total loss for processing this case worth very much?
Yeah, they're not going to get anything.
Is any other type of provider going to be able to explain and do what we're talking about right now?
No, they can't.
That's right. This is how big the market is. This is huge. And this is very important for this guy. This guy's going to have problems the rest of his life. He deserves some compensation.
Yeah.
So that's the difference, not just monetarily and making the money and all that. You're making a significant impact, and you know this you should be. This case, I'm telling you, with my attorney, with this case, in other words, if I kind of end up the case with kind of what we're finding here, in other words, we go through the 3 ranges of motion, and we have kind of what we have documented right here. In other words, I'm at the end, not at the beginning or the middle. I'm making sure, remember, you should at least contact your attorney 3 times. Right after the initial exam, give them a heads up of your findings, which are going to be influential in the financial driver category. You should get a heads up right away. After the first re-exam, you should have a trend line. You should now know, is this person getting a lot better faster? Are they not getting better, or is it getting better real slow? In other words, what are my financial drivers looking like for the attorney? I need to pick up the phone and call him. And remember, this is an attorney you should have already educated on this material, right?
Yeah.
And if you haven't, is this not a great case to go to this attorney and do one heck of a sales job educating him on how you can create an unbelievable amount of value for his soft tissue cases?
Yeah, it is.
This
I'm
is
going to call him up. Yeah, he's meeting with his attorney, and I might go with him on that first date.
This is not a phone call to an attorney that I have not educated. This is a meeting. I need to take him through and do an educational sales on him to where he sees I know how to put this case together, okay? And I'm using I'm using, is he going to pay a lot more attention to me? Yeah, because it's his patient, it's his client. So when you,
just real quick on this case, like the attorney, this guy Craig, he is gonna go meet that attorney for the first time in the next week. Would it be okay? Now Craig's a personal friend of mine. Would it be okay if I go with Craig and we all sit down for an hour and I demonstrate all this in front of Craig and in front of the attorney? Is that okay?
based on what you've learned up to this point, that would be a question you would not have asked. But having said that, what do you think the answer is?
I don't know. That's why I'm asking.
Well, based on what we've covered up to this point, you should know. Do you know the attorney? Do you know this attorney? I take it you don't know him.
Yeah, I've met with him once before, just when we visited about some of the stuff we talked about here that you shared with me.
Okay.
So he's not like my attorney, but we get along.
Okay, well that's a little different, but here's the bottom line. We buy things in a 4-stage process, right? So if you didn't know this attorney and you're going over there trying to sell him on the first visit, how smart is that?
Not super smart.
It's not smart at all. We want to set it up. In other words, we want a few contacts before. So this is a classic example where I would call the attorney, give him a heads up of what's going on with some of these financial drivers. Then I would send him the full video of exactly how we document that we created with you. You have this, and it's real easy in your link. You could just send him the link directly that gives the whole video presentation. Say, let me send you this. This information is directly related to your client. Now, what's happening with the contacts, with the phone calls, the video, the visualization? What's happening with trust, defenses, and resistance? And by the time you get to him, where's he in the sales cycle now? Definitely not in the first step. You never want to try to sell somebody in the first contact. Never. Okay? So that would be the cycle with this. He'd have gotten a phone call. So you talk to him. He'd have gotten a phone call and a heads up. I'd have sent them the video series showing him to affect all that. So now I'm calling him back and say, hey, let me go ahead and cover that material relative to your case. Where are you at in the sales cycle relative to trust, defenses, confidence, and resistance?
Well, you're a lot further along. You've got better than everyone.
Exactly.
Entire trust.
Exactly. And where's he at in the 4-step sales cycle? He's in the third phase. He's not in the needs phase because we've increased his awareness, interest, and desire through the cycle we've affected. And he's in the obstacle. He's in this third phase of the sales cycle. So he's way more receptive. His defenses are down. His trust is high. His interest, remember, he didn't even have an interest in this when you first talked to him. He didn't even know it existed. He was in a state of unconscious incompetence. So now I'm in the third cycle of the phase cycle. That's where you're going to give the presentation, nail down the issues, and eliminate the obstacles. That's how this would be handled relative to communication, okay? Okay? So we're moving ahead here. So we're good. Let's just keep moving. I think we've said enough about the x-rays. So if you get a disc lesion on top of that, I mean, what kind of case do you got now?
This is slam dunk.
This now becomes a big case. You have a disc lesion on top of these altered intersegmental motions, and it looks like you have an AOMSI in here. So you have an alteration of motion segment integrity plus altered spinal mobility in the cervical and lumbar spine, right? Because in the lower spine, let's say that one segment was AOMSI, right?
Right.
Are the other segments altered intersegmental mobility?
Yeah.
Yes. Yes. So you not only have an AOMSI in the one segment, you have altered intersegmental mobility in multiple lumbar and cervical segments. Add a disc lesion to that. How big of a case do we have here?
Should be huge. This
thing is getting big. Now, obviously, I got to complete the package, right? I got to follow this whole thing through. So here we go. Now, is your attorney going to know any of this? No. No, not many people know what we're talking about right now. And that's the huge opportunity. So let's say we finished with our objectification and quantification, okay? All right, therapeutic protocol. What should your therapeutic protocol be? It should be, in other words, what it is you do should totally be based on the 3 phases of healing. And that's in your report. It's in your notes, it's in your narratives, it's in your testimony, it's in your deposition. That's why. So you should be able to explain what that therapy does and the effect it has on whichever 3 phases of healing you're using it for. What are you trying to do physiologically? And you should have it benchmarked, right? With periodic re-exams. The re-exams are essentially every 30 days or every 12 visits. Initially, it's every 30 days for the first 3 months, and then typically it can go every 12 visits from there. But you're benchmarking, so you got the daily SOAP notes, you got the benchmarking of the re-exam, you got your functional capacity test, right? Your oswestry scales, your neck disability index, right?
Yeah.
Okay, you're totally supporting the need for care and what you're doing. You're quantifying, benchmarking, and supporting therapeutically. And then, of course, your treatment protocol, on your frequency of visits and what you do depends on that. So we're covering a lot of good financial drivers that need to be. We're not making anything up. We're documenting what's obvious, what's there, which gets missed most of the time. Now, so that takes care of the duties, the therapeutic protocol. Now, would it be nice if we had a parallel from a supportive standpoint? Would it be nice if we had our medical team support what we're doing in the inflammation phase, Tom?
Oh, yeah, huge.
Are you with me on this?
Yeah.
So we not only have more credibility and authority here, but also the financial drivers. Medications are financial drivers. You don't give medication unless there's a problem. So in the inflammatory phase, would it be important that this person also be engaged with your medical team?
Yeah.
Do you see the importance of this, Tom?
Yeah, absolutely.
Instead of you just being a lone wolf, and guess how your attorney is looking at you now as you're doing all this? He doesn't see you as a wacko out in left field now, right?
Right.
And my medical team, I set up because remember, I never want to send patients to somebody I haven't met and don't have agreements with, right?
Right.
I don't want them saying and doing things against chiropractic, and I want them supporting the patient. I don't want their agendas getting in the way here. So, we're quite familiar of discrimination in healthcare, aren't we?
Yeah.
Okay. So I'm making sure that my medical team is on board. This is a team I created, and I've laid down the law and the guidelines of what I expect, or they're not part of my medical team. They don't get my referrals. So in the first phase, I'm looking pretty good. I got my medication. In the second phase, you're going to do your passive modalities, etc., your active therapies, right? Your active passive as you take them through the 3 phases of healing, right?
Right.
On the medical side, in the second phase of healing, they may or may not need injections, pain management, right?
Right.
I don't know this case. Does this guy maybe need some pain management?
Yeah, he pretty much he was living off of Aleve, and now he still takes it probably 3-4 times a week, and it's still on light duty.
Okay. Well, I'm also I'm going to get a pain management consult with a pain management doctor who I've already brought into my team, right?
Right.
What's happening to this case? The value of this case, Tom?
It's jumping.
What's happening to your credibility?
It's super high.
Now, do you think you want the sublet station or the medical team?
I want my medical team.
You get my point?
Yeah, I get your point.
Let's get on board here.
You're not being very vague here.
That's right. I'm nailing this. I don't want them to say anything I say or doing isn't right. I don't want to be questioned. And I'm using credible sources, credible equipment, credible diagnostics. I don't want to bring in something to muddy the water here. So that's my pain management part. By the way, I've already got that. And by the way, I should already have had, does he have neurological symptoms, tingling, numbness, anything like that?
Well, yeah, and the big thing is his legs started to lose strength in it for a few weeks,
Okay.
and it came back. But yeah, his legs started flaring out when he walked, and we adjusted a few more times, and then it started to go work again. It
Okay.
probably still does once a week,
Does he?
but doesn't walk. He
Is,
can't walk right.
okay. Is that enough for a neurological consult?
It started to get better with just adjusting, so I didn't. And I also don't have. I've met with some neurologists, but I wasn't sure if I should refer him right away.
Well, let's just. Does he have any radiculopathies?
Yeah, down the left leg, same leg.
Okay. If the radiculopathy has been there for any amount of time and isn't responding to any degree, and the degree of the severity of the radiculopathy, is that a justifiable reason for a neurological consult?
Sure.
Yeah. So now, Tom, is there anything wrong with getting a consult? I didn't say get a procedure. I didn't say go send them for an EMG and an NCV, did I?
No.
Well, why not, if he has radiculopathy, why not get the neurologist's opinion who's on your team?
There's no reason. In fact, in this case, I went and met some neurologists to see if I could, just establish a relationship and then send the referral to them.
Okay, you see how we're putting this case together?
Yes.
And how much, by the way, how much are you helping this patient by doing all this?
A huge amount. They wouldn't get anything if I don't put this together.
That's what you should be doing. It's borderline malpractice when you don't do this.
Okay.
So you have a duty, if the tools are available, for you to use them in your diagnostic and therapeutic protocol, or it's malpractice. You have a duty. So if he's showing he has neurological symptoms, radiculopathies, weakness, yeah, I'm definitely getting a consult. Does that mean I'm going to say, yeah, do an NCV EMG? No. Let's send them over to, why don't we send them to somebody who might be a specialist in nerves, right?
Right.
And okay, so I'm going to get his opinion. He's my team. Okay? I want to get his opinion. So he may say, no, let's hold off and do treatment, right? But now look how much more credible you are.
Right.
Okay? So at least get the consult. The consult. And obviously, if he had a disc lesion too, I would probably getting an orthopedic consult, wouldn't I?
Right.
Okay? These are important. These are important. Am I protecting my patient by doing this?
Yes.
Yes, I am. I'm protecting him. I'm looking out for his health. So that is you, not just in the therapeutic protocol of you doing your pillars, but also making sure you're nailing the financial drivers, as well as managing your case, as well as bringing in your medical team to totally. Now, what's happening as I build this case? You're the attorney on the other side. Prior to this, the only experience you had with the chiropractor is you did a deposition and the guy only talked about subluxation and a subluxation station. That's all he did. So that's all you know as the attorney. Now you're the attorney. You come across me. I'm putting this case together like this. You see it in the notes, reports, and deposition. How you feeling about me, Mr. Attorney?
Not too excited.
You think you might be a little shaky that he's not dealing with a weak chiropractor?
Yeah.
You see, Tom, do you understand this difference? This is not minor. This is major.
Yeah, I do.
This is the difference between playing little league baseball and the major leagues. This is the difference right here.
Right.
Stop thinking like a chiropractor. So you, and I mean that from the, obviously the philosophical, not the clinical, helping the patient standpoint. So I've got my medical team and I'm moving the case through. We're going through his treatment plan. Everything's justified on what we're doing, how we're doing it. I'm bringing in specialists as needed. I'm quarterbacking the case. Guess how well your attorney likes you?
He loves me.
When he sees this in the final report, who else is he going to want to deal with, Tom?
Nobody.
That's how it works, Tom. This is exactly how it works. And it doesn't take a whole lot more. I mean, you have to be more knowledgeable, right? But are we
Right.
really talking about a whole lot more effort to do one heck of a better job?
No, it's just practice. So I start putting. I just have to practice this. The first two or three I do is going to take some time, and then it should get much easier.
Yeah, you're
Because
exactly
I got to
right.
remember how it's all organized. It's
Yeah,
not. I'm doing 70% of it. It's the other 30% that'll quadruple my value.
yeah, and that's my only point is when we're in a state of unconscious incompetence and not really knowing with clarity what to exactly do, things always seem way more overwhelming than what they are. But as these steps become clearer and clearer, it really doesn't take that much more effort. I mean, you have learned a lot, right?
Yeah.
Yeah, okay. So, I mean, you do have to learn some stuff, but compared to the magnitude of what you could do to help these people, we're not talking marginal, are we?
No, it's huge.
Look how much more better of a practitioner you are. Look how much more credibility you have. Look how much more you're going to be able to access the market that you didn't even know you were blocking off.
Right.
Okay, that's how this all goes and comes together. So we're in the third pillar. Any other objective findings that we need to be paying attention to? The common ones?
Um, any more objective findings? I think I've got most of them.
Let me point out a couple things. We talked about the orthopedic neurological testing. We talked about the neurological consult. You're getting the MRIs. We talked about the alternate intersect motion, the motion studies. So we got everything here. The one thing that will really help, and a lot of people miss this, is should we probably have done some blood work on this patient, Tom?
I don't think so. I don't know why we do blood work on them.
Okay.
What are
Okay.
you looking for?
Okay. And if you don't know what to look for, you wouldn't know what to order, would you?
No.
Okay. Now, is blood work a high trust category?
Very.
Is it a medically accepted high trust, high authority category?
Absolutely.
It's huge. So we want to pay attention to blood work. Now, relative to this case, what's some common blood work that we should have done? Well, we should have, now, depending on when you got the injury, but I'd be doing it anyway, is you definitely should have did a sedimentation rate, right? And of course, that varies on when you got the patient and when the injury occurred, right?
Right.
Okay, because a sedimentation rate measures the protein in the blood through trauma, right?
Right.
So is that a blood work we should have done?
Well, I would say yes, because it establishes that the person was severely injured.
That's right. That's right.
But I thought we already did a great job early on. I mean, his pain is through the roof. He's taking medication. He can't work. My question is this: we've already done a great job showing it on. At what point does it become overkill? And the real question about the value of this case isn't how bad he was hurt early on. It's at the end of the case. And so is there blood work that would be more valuable that you want to take at this point in the case when he's not improving?
No, wait a minute. You just said two different things. Let me go away from your statement of, at this point in the case. I don't want to talk about that now. I want to talk about blood work. And you're telling me you don't want to run a high authority, a high scientific test that definitively shows an injury. Is that what I just heard you say?
Okay, well, if you want to put it like that, it sounds a little different.
Isn't that what you just said?
Yeah, that's what. Well, I said it's an overkill.
And let me say again, you do not want to do a high authority, high trust, high scientific test that will definitely help increase the credibility and not only identifying the injury, but the magnitude, the quality and quantity of an injury. You're telling me as a physician, you don't want to order that test?
No, you misunderstood me. I said I absolutely want to run that test.
You get my point, don't you?
Yeah, you make your point very well.
Okay, yes, that is a huge. Let's see. Do I want to run a blood test and have positive sedimentation rate or a subluxation station, and have which one do I want to go to court with?
Now you're just making fun of me.
You got my point, right?
Yeah, I got it.
Okay, now so we're talking about blood work. What is some common blood work that is very easily to do with neuromusculoskeletal trauma? Well, the sedimentation rate is real common. That's a common blood work. Another one is C-reactive protein. Those are inflammatory indicators, right? Sedimentation rate measures the amount of, and basically when you look at blood work, you're looking at the amount of protein in the blood, essentially, right? Because when there's damage to the tissue, there's more protein, right?
Right.
So the sedimentation rate is protein, and then also the C-reactive protein test. That's a highly sensitive. That's a test used most commonly for an inflammatory indicator for cardiovascular disease. But do you think that that might be important to see an inflammatory indicator?
Yeah.
So I'm going to pay attention to these inflammatory indicators. What's another common inflammatory indicator? Now I'm talking really basic stuff. This is just run-of-the-mill trauma blood work, right? I'm not talking about unique testing for, you know, a genetically disease that you see once every 50 years. That's not what I'm talking about.
Right.
I'm talking about basic stuff here. So a sedimentation rate, yes. Should maybe a C-reactive protein to check inflammatory indicators? Yes. What about a lipoprotein ratio, high density lipoprotein ratio? Yes. Those are now those are a little more systemic inflammatory indicators versus traumatic, right? There's traumatic inflammatory indicators and then systemic, right? But my point being is it highly valuable to have high third-party trust scientific-based blood work that show inflammatory indicators that show trauma has occurred?
Right.
You think that's more important? Or are you staying on the stand? Yeah, he hurt himself.
No, it's more important.
Yeah, Tom. By the way, blood work is one of the most, it's actually the single most thing you could do to establish credibility, blood work. Everybody already knows if you do blood work, you're a doctor. That's the society. In other words, our culture, our society totally accepts blood work, right? That is the number one high trust third party thing you could do, scientific based, to increase your credibility and your trust. And I'm not even talking about helping the patient here, am I?
No.
Okay. So yes, you should have run basic blood work with those panels. Real simple. What?
No, can I just send them do I send them to my pain doctor and say, hey, I want this test run or this test done, or do I need to establish a medical doctor, or do I hire a phlebotomist to come in and take blood for me and run it directly?
Yeah, that's a real good question. And that answer depends on your state law. If you cannot order a blood test in your state law, then you can't. Then you need a provider and say to that provider, hey, I'd like a consultation. And if you feel it's necessary, would you consider ordering blood work? That's kind of how I would say that. So it depends on your state law. But most state laws, chiropractors can order blood work. Now, most states, you can't do blood work, right?
Right.
And you don't want to do blood work. With OSHA and OSHA laws, you do not want to do blood work. So it's really easy to go, and there's these little labs everywhere. The LabCorps, and they're right around the street from you. And guess how much resistance you're going to have for a patient saying, we're going to do blood work? Guess how much resistance you're going to have for that?
None.
None. Why?
Because they're used to it.
That's what they get. Every time they go to the doctor does blood work. I am telling you, it is the single best thing you could do for credibility. And it's tremendous, to help the patient to document that this person does have some internal inflammation. Everything I'm saying, look out. Now, you're the defense attorney on the other side. What's happening to your ante? How much you're willing to pay for this case, Tom?
It's going way up. You don't want to go to court.
You get my point?
Yeah.
And he sees that I know how to explain this in a deposition. First, he sees it in narrative reports, right?
Right.
So he sees all this documented, and when he sees that narrative report, and it's all based on third-party high-trust factors, and you're able to correlate everything like we're doing right now. Does he even want to go to a deposition?
No, he doesn't need to. He
Now,
knows what you're going to say.
That's right. Now, let's say your attorney's asking for, way more than they're even willing. By the way, how much are they willing to pay at this point after reading this material?
A lot more.
Okay. Now, let's say that they don't want to pay the enormous amount your attorney's asking for. So it does go to a deposition. Then you are in the deposition and you know how to do this. You know how to take them through all of these steps, connecting all these dots. You just showed him what the jury's going to see, Tom. What's his likelihood of wanting to put you in front of a jury?
He doesn't want to.
That's right. Does he want to leave liability and an injured person in the hands of blue-collar workers?
No.
Against the big insurance company?
No.
Do you get my point here?
Yeah.
This is important stuff, Tom. This all matters. It all adds up. So you're having tremendous impact and influence, not only in this person's life. Who's the best doctor this person could have showed up to, Tom?
Me.
You. There's nobody else that could help that guy like you're helping him, is there?
No, there isn't.
That's right. Doesn't come close. So the blood work, I would consider that, and basically it's three major types of categories: sedimentation rate, the C-reactive protein, and the lipid profile. It measures the high density, low density, and cholesterol. The ratio of those lipid profiles are inflammatory indicators. Okay. So
these are all great to run at the beginning.
Yes.
Is there any value? Like, I have two patients this guy Craig, it's been 3 months. He's plateaued in his care, and he still has a tremendous amount of pain when he tries to work or do things like that. Is there any blood work? Are these tests still valid and helpful to establish that there's a problem, or are they gone already?
Well, what if he? You can go into the book to find the details, but here's the bottom line: if he has chronic inflammation, is he going to show inflammatory indicators?
He should.
That's right.
How strong are they going to be? And
that's right.
Are they valid?
That's right. That's right. In other words, if it's there, right? Yeah. So if the problem is a chronic inflammatory condition, and it looks like you kind of have that here, does it not?
Yeah.
So he's going to have these indicators. So even though maybe you didn't order them initially, I'm going to order them now. And if I did order them initially, am I going to want to follow up with that blood test in my benchmarking?
Yeah, I do.
Yes, I am. I'm going to want to quantify that blood work in my benchmarking. Yes, I am. Okay? Okay. And I will tell you soon, you doing one thing, it does something with credit. Now, once you start talking about using third-party scientific tools and basing everything on the 3 phases of healing, your credibility goes up significantly. Now, when you bring in a medical team, your credibility goes up even way more. And I'm telling you, when you start doing blood work and everybody sees you as the doctor now. It's the single most thing you could do to increase the trust and credibility of your office, blood work. In other words, you're leveraging off what the community already trusts. They already believe it and trust it. You're connecting yourself to something that they already have high authority and trust to. Okay? And now you're not some wacko chiropractor coming into a deposition with no medical team, no third-party trust factors, no blood work in your subluxation station. Big, big difference. Okay? All the while, how's your attorney liking this, Tom?
I'm making his job easy. He loves me.
Tom, you are making his life. You are going to put him in a higher economic category. Do you understand that?
Yeah.
He's going to be going to the country club now because of you. He's going to have a much bigger house because of you. That patient is actually going to get better care in the future because of you and your ability to do what you're doing right here. So those are some of the objective tests. We talked about your therapeutic protocol as the third pillar, right?
Yeah.
Okay, so we quantified, we explained why we did what we did based on the 3 phases of healing. That goes in your notes, your deposition. Just match what you're doing, what it does with why you're doing it relative to the 3 phases. You're going to benchmark it, right? You're going to show initial exams, re-exams, follow-up re-exams. You're going to show the difference and then just state the differences of what was improved, not improved, or stay the same, and give your opinion as to why. Why do you feel like the person's not improving more? Maybe, and it might have to do with their age, that it might have to do with their work. It might, might have to do this because they have diabetes, or so I'm going to give my opinion as to what I'm seeing in the difference in the benchmarking, whether it's better or worse or the same. I'm going to give my opinion. So I've explained what I've done. I've explained what I've done with the therapeutic protocol, why I did what I did. I benchmarked it. I quantified it. Okay. Now I've taken it through, and now I'm past the. I'm well into the remodel phase, right? And now I don't see any further improvement, right, from one exam to the next, right? Okay, now I'm getting close to MMI, right? Maximum medical improvement. I'm not seeing any more symptom-wise or physiological improvement over a period of time from one benchmark to the next. So let's say you go 2 re-exams and there's no improvement, and I'm well into the remodel phase. Am I much more positioned to give an authoritative perspective on permanency?
Yeah, you are.
Yeah, and that's where you should be giving it. Not in the repair phase, you shouldn't be giving it there. You should be giving it well into the remodel, and your attorney needs to know this, right? So it should be well into the remodel phase. You've got your whole team coming together. You're now leveling off. We're now going to start dealing with some permanency. So we go ahead and we don't see any more marked improvement. We've done the referrals. So now this guy's got a permanent injury for whichever one of these factors is permanent. Now I'm going to do my baseline analysis, right? I'm going to do my release exam. So I'm going to go through and do all the tests, the final tests, measure everything. Now I have my final documentation, range of motion, subjective, objective, diagnostic testing, whatever. I now have it. I have my quantification and objectification and quantification for permanency. I'm done. My case is done. Now I got to put my report together, right? So I'm going to get all the information, get all the notes from the other providers, bring it all together, and I'm just going to start from the beginning, Tom. I'm going to go from the mechanism of his injury. I'm going to explain everything I just went over in a narrative report. I'm going to do it in a micro cassette recording, and I'm going to do it just like I'm talking to you. And I'm just going to walk through the first pillar of cause and effect. He was here, he got hit here, these are all the factors, and I will put emphasis on what is a greater factor or lesser factor, such as the joint locked out, the joint wasn't in the right motion, it had a soft tissue versus a hard tissue, a big truck versus a little truck, it's sliding 10 feet. I'm going to say cause and effect, and I'm going to put and emphasize these factors to totally lock down cause and effect, okay? So that's it. This is my report, my narrative. So after that, I'm going to the second pillar, which is these were the symptoms that he had as a result. And then I'm going to go into my objective test. I'm going to go get all my reports, my MRI report, my NCV report, my computerized radiographic mensuration report. I'm going to get all my reports. And I'm going to comment on every one of those reports and what they mean relative to his injury and permanency. And obviously, what's that based on? Those objective findings are going to be totally interpretive based on what? The 3 phases of healing. That's how I'm going to be able to say with certainty that there's permanency here. It's not my opinion, it's third-party trust. This is how we physiologically heal. It's not a little chiropractor's thought process, okay? I'm explaining what is universally accepted, and I put him into the model. So this is my narrative report. That's what I did. So I nailed down my first pillar, cause and effect relationship, emphasis on what I needed to. Number 2 is the second pillar, all the objective findings that I feel were related to that injury. I should have some, all my stuff together. Bring in all your other providers, your blood test report, your computerized radiographic mensuration report, your orthopedic second opinion, the MRI report. I'm going to bring all these in. I'm going to put them in there, and I'm going to comment on them. I'm going to make a comment as to that injury as it relates to that cause and effect. Okay. Then I'm going to go into my benchmarking. I'm going to go into, this is where they were. This is with, with my ranges of motion and my orthopedic test and my neurological test and whether it was an NCV, MG, motion study, whatever. Then I'm going to put all that out there and explain the benchmarking. By the way, at the end of the exam is also when I'm going to do my duties under duress, enjoyment of lifetime activities, restrictions and limitations, inhibitions, right? That's at the end because those are permanency statements. And I want to make sure the patient understands, because remember what I said before, patients forget, when they have pain and discomfort and they stop doing things, they won't remember 6 months later to tell you, oh yeah, I can't do that anymore, because they stopped doing it. And now they're taking pain pills and they kind of stopped that activity they did periodically. Like say they really enjoyed planting flowers. That was a hobby and they can't plant flowers anymore because of that particular condition. Well, a hobby is a major restriction or limitation. If you can't do a hobby, that's a major component of life. Hobbies are a major component of life. Okay. So I've instructed the patient how to fill this out, what to pay attention to, specific emphasis on the overpressure activities. Have him fill that out. I've got, especially in this case, I've got something here. This guy has some restrictions and limitations in his life in many places, not just activities of daily living. He's got some problems. So I'm going to be documenting all those because I got the paperwork. He filled them out. So I'm just explaining them in my report as I'm going through the objectification, the benchmarking, whether it's the neck disability index, osseohistory, whether it's your physical exam findings, and then explaining, comparing and contrasting, range of motion. And I typically do tests. I kind of do tests. Range of motion, I go, it was this date, this date, and this date, and then I'll explain the pros or cons and why. Then I'll do these tests, this date, this date, and this date. And in other words, I kind of stick with one and I do a trend. It's easy to follow something if I follow the same thing, AAA versus ABCD, ABC. That's a lot harder to follow in that format. So I went ahead and documented everything, including the findings. I got them all in my report. Those are addendums in my narrative reports. And then I'm going to give my statement of permanency. And that's obviously your opinion. That's based on the 3 phases of healing. And now you have to give your opinion why that is a permanent injury and the limitations and restrictions they have and why. That's the duties under duress, lifetime enjoyment activities. You should be able to explain those and interpret those relative to the 3 ranges of motion and the permanency of collagen when it heals, how it's never going to change again. Now they just need subjective palliative care. Their collagen's not going to be synthesized again. It's over. And that remodel phase is close to over. It's over. It's done. And you should be able to explain that. And that all comes from the knowledge of the 3 phases of healing. That's what it's all based on. So we explained all the factors with the ranges, the objective factors, the benchmarking, the capacity indexes and all that. And then you're going to give your state of permanency with regards to every injury, what is expected relative to restrictions, limitations, and future care. Give your statement as to restrictions, limitations, inhibitions with those particular activities and relative to the need for future care as a result of this. Because remember, one of the major components of compensation is future care. That's a major mathematical part of a case value is future care. So you were able to document, show, and support all that. So look what you're able to do. By the way, look what you're able to do for the patient, for helping him getting his future care paid for. Is that not a valuable thing? Would you not want a doctor to be able to do that for your mother or father? Do you get my point?
Yeah.
Okay.
Yeah.
So you're becoming a very valuable clinician. Very valuable. And so that's how you finish the report. That's the narrative. That is how I wrote the narrative. And I wanted to make sure that in that narrative, I put in the things that I know they're going to try to attack me with. The pre-existing problems, or that injury couldn't have been, it wasn't that magnitude of an injury to cause that. I'm paying attention to that as I go through with emphasizing what I need to emphasize to help minimize or put that in its perspective. And that's my report. That's the report that I send in as my final report to the attorney. Most of the times you have to educate your attorney to request this. If your attorney doesn't have this information to put into his demand letter, then that's not good. And most of the attorneys you're going to find don't know. I'd say 3 out of 4 attorneys don't know what we just covered, or a good deal of what we just covered. So when you're essentially handing him a gold mine, he's got to be smart enough to know what he's looking at and to ask for compensation for all these factors. And so you have to educate him on these things, Tom, and not take for granted that he knows how to do it just because he's an attorney. Okay? You got to remember, most attorneys have never been to court. You know, and they don't, a lot of them don't even want, you know, they just want to process the case. They don't really understand the value like this case. This is a very valuable case, not just for the attorney, for you, but the patient. You're going to help this patient in so many ways. You may be able to help this patient not only with future care and all that. You may actually get him to be pay for his schooling and his education and rework or whatever. I remember I had patients who had jury verdicts for X amount of care the rest of their life. The insurance paid for it. I had a few patients like that they got those in the verdict. Okay, that's very valuable stuff to help the patient. Okay, so that's the summation of the report and how I would just flow through the report. And again, it's just on a micro cassette recorder. And I'm just starting from the top and connecting all those dots all the way through in the micro cassette recorder. Okay? Any questions about that?
No, this was really good. I learned a whole bunch of new stuff. So this was super valuable.
Okay. Now, can you see how you're not going to lose this case?
No.
The question, the question is not if you're going to lose the case. That is not what becomes the question when you know this. The question becomes is how much are you going to win?
Right.
That's what the question becomes. And so I told you I never lost in court. Now I told my attorney when he did not need to go to court, and definitely not go to court because I won't have what he needs to support what he's asking for. So I made sure he knew that, or they knew that. But when I had a case like this, guess what I would tell the attorney with this case?
What?
Go for it all. Am I going to be able to back this attorney 100%?
Yeah.
Go for it all. I'm going to tell him to take his formula of care and work and age and lost income possibly and future care and all that, okay? I'm going to say, I want you to maximize that formula out. Don't consider average and don't go low. I'm going to say, go for the top end. I said, and I'm going to show him everything that I got. Now, if I showed that attorney everything I got and how I was going to explain it to a jury, how much you think he's going to be willing to ask for? And I'm not asking for a dollar amount. I'm just saying, you think he's going to ask for a heck of a lot more than when he dealt with you prior to you knowing this?
Yeah, he's going to ask for policy limits.
Totally. This is a policy limit case, is it not?
Yeah, it is.
Yes, it is. With you at the driver's seat, this is a policy limit. And I'm letting him know that. I have to educate the attorney. See, I keep saying that because so many doctors I work with think the attorneys know all this. And they do not. They take so much for granted. So you have to do educational sales to be able to share this with the attorney to get him up to speed, or he'll botch it. Okay? All right, any other questions in regard to this case, Tom?
No, there's a few things I'll ask you later, but this has been really clear. This is really thorough, so good.
Okay. All right, let me go ahead and stop it here, and we'll turn off the recording at this point, okay?
Okay.